To defeat an enemy, it's always better to have multiple types of weapons. For example, to win a war, you need a good army, you need a good navy, and you need a good air force. To defeat the enemy in front of us, the chronic subdural hematoma, today I would like to introduce in the next 15 minutes a new weapon which we have, which is called the middle meningeal artery embolization. In the next 15 minutes, I'll just share with you 10 points or 10 things or 10 answers to the 10 questions why a neurologist should know about chronic subdural hematoma. I don't think there'll be any neurologist in this audience who doesn't diagnose at least one chronic subdural hematoma every week. It is one of the commonest neurological diagnoses in the elderly population. The patients come with very vague symptoms like mild cognitive decline. It is one of the commonest cause of reversible dementia in the elderly. Mild lower limb weakness, sometimes with bladder symptoms, incontinence of urine, some very rarely with new onset seizures of the elderly, severe headache, or sometimes with early Parkinson's symptoms. Many times, as all of you would have experienced, the chronic subdural hematoma is not immediately seen after a minor head injury. The initial CT may be normal. Then 2 weeks or 3 weeks later, the patient comes with recurrent episode, very mild neurological symptoms, and a repeat scan. You'll be surprised to see that there is a huge chronic subdural hematoma. The incidence of this is increasing. One, because of the aging population is increasing. The use of antiplatelet medications, especially above the age of 60, is significantly high. There will be very few people who are not on antiplatelet medication above the age of 60 or 70. The indications for anticoagulation is also increasing, and it's one of the commonest sentinel event. Sentinel event means when the patient becomes elderly, 80 plus, usually the deterioration starts with a chronic subdural hematoma, and because of the comorbidities, they deteriorate and eventually they die. It is expected that the incidence of or the prevalence of chronic subdural hematoma is likely to double in the next 10 years. So it's going to be a significant neurological problem faced by neurologists. The question number 2 is, what produces chronic subdural hematoma? It might be easy to agree with the traditional thought that there is a minor head injury, there is a rupture of the bridging veins traversing in the subdural space. This leads to leakage of fluid or blood into the subdural space because of brain atrophy. The bridging veins is unsupported. Maybe an acceleration, deceleration injury precipitates that. Minor head trauma can precipitate that, especially in people who are abusing alcohol and people who are on antiplatelet medication. But there are many things now, many factors or many issues which raises the doubt that it is not as simple as that. One, it's usually a minor head trauma, and if it is only a bridging vein rupture, there should be a localized bleed in that particular area only. But on the contrary, in a chronic subdural hematoma, it is not the blood alone. Usually, it is the blood degradation products which extends extensively over the subdural space, right from anterior to posterior, and that too it develops over months or weeks. Gradually only it expands, and it continues to expand also. And there are features which suggest that there will be a continued leak also or a bleed also later. So there is a lot of inflammatory process, neoangiogenesis, new blood vessel formation. These leaks which are highly permeable, this leads to collection of the fluid or blood degradation products in the subdural space, especially from the outer membrane, which becomes inflammatory, new vessel formation. There are a lot of changes which contributes to this development of chronic subdural hematoma. So the outer dural membrane, which undergoes this inflammatory change, neoangiogenesis, vascular proliferation, all this is the culprit which contributes to the leak. So essentially, there is a minor head injury which initiates the process, but the chronic subdural hematoma develops over a period of time, and the pathophysiology is significantly contributed by the external dural layer, which is the site of leak. Now, what are the types of subdural hematoma? It is not a single entity. This is an acute subdural hematoma, an acute bleed. You can see that the acute blood in the subdural hematoma. These are different types of subdural hematoma. What is seen here is layered subdural hematoma. You see one layer here, another layer here. This is another septate subdural hematoma where you have septae in between, dividing the subdural collection into different cavities. So this obviously suggests that the collection occurs over a period of time. There is one layer forming, collection occurs in that area, another layer forming, another cavity forming in that area. This is another subdural hematoma with two layers. This is another subdural hematoma with two layers. There is septate subdural hematoma with multiple pockets of collection. And this is another cavity showing two layers of subdural hematoma. One layer here, one collection here, another membrane here, and another collection here. What makes this interesting or difficult for evacuation? It becomes difficult. Just putting a burr hole one may not be able to evacuate the subdural hematoma completely. This is another subdural hematoma where you can see a level suggesting that this is a patient who is probably taking anticoagulant medications, so that there is the blood is not clotting in that particular area. So this is a chronic subdural hematoma. This is an isodense subdural hematoma, which the density of the fluid is almost same as the blood, the brain parenchyma. This is another subdural hematoma. This is the layered subdural hematoma in a patient who is taking anticoagulant medication. And this MRI shows that there is a significant inflammatory response of the underlying parenchyma. So these are the subtypes of subdural hematoma, especially the figure number F, where you can see there is a significant edema or inflammatory response of the underlying parenchyma. And these are the patients who come with significant headache, very severe headache, and second, with encephalopathy, alteration in sensorium, third, with recurrent episodes of seizures. This is an isodense subdural hematoma where it is at times difficult to differentiate the hematoma from the underlying brain parenchyma, which becomes even more difficult when there is a bilateral isodense subdural hematoma and there is no midline shift in that particular patient. And this is a bilateral chronic subdural hygroma, and definitely all of you will agree that in such patients one should suspect the possibility of a spontaneous intracranial hypotension. So obviously there are different types of subdural hematoma, which makes the management of these lesions technically difficult. Fourth, what is a traditional surgical management? The number one option is to put a burr hole and drain the fluid what is collected in the subdural space. So, but obviously, as we have seen from the different types of subdural hematoma, when there is a septate hematoma or layered subdural hematoma, just one burr hole and evacuation will not drain out the complete fluid in the subdural space. In which case, a craniotomy has to be done and all the membranes needs to be resected extensively. Now, 5, what are the issues with surgical management? The number one issue is incomplete evacuation, especially when there is a extensive subdural hematoma, bilateral subdural hematoma, layered subdural hematoma, septate subdural hematoma. Evacuation is usually incomplete with one burr hole. One needs to put multiple burr holes. Second issue is recurrence. At least up to 30% of people with chronic subdural hematoma have a recurrence after surgical evacuation, needing a repeat surgery or craniotomy or putting a drain in such patients. There are multiple factors which contribute to the recurrence, especially patients who are on antiplatelet medication. These patients, especially who are the elderly, when they require an ICU admission, under anesthesia, the procedure has to be done. They need to be restarted back on antiplatelet medication or anticoagulation. For example, a patient with embolic events after an atrial fibrillation, a patient who has got a coronary stent in situ. All these patients, antiplatelet medications, anticoagulation needs to be continued, which makes incidence of recurrence much higher. Also, the management becomes difficulty. These are elderly people with multiple comorbidities, and usually they go step by step down. May not be directly related to that because there will be multi-organ failure, infection because of the ICU, bedridden state. Now they are because when they have a drain, they need to be bedridden for at least few days, which starts the downhill course and becomes the sentinel event. And last but not the least, surgery does not address the primary pathology, which is the leak. So essentially, it is a leak and fluid collects. So just putting a hole and draining out the fluid does not address the pathology, which is the inflammatory response and angiogenesis and the neovascularization occurring in the dural layer. So this is where the new weapon called middle meningeal artery embolization helps. Let's see how middle meningeal artery helps or contributes to the development of subdural hematoma. Middle meningeal artery, as you know, is the main arterial supply of the dura, and that way this contributes to the it's a main contributor to the leak in subdural hematoma. So when you obliterate the middle meningeal artery or devascularize the dura, there is a halt of the neovascularization. This once the leak is stopped, the collection, there is an opportunity, then there is no leak. Whatever fluid is collected in the subdural space will be reabsorbed without any recurrence. And last but not the least, obliteration or occluding the middle meningeal artery is a simple procedure. It is a minimally invasive procedure where you don't have to open the skull, just a femoral artery puncture, go directly into the external carotid artery. Let's see how middle meningeal artery embolization is done. So one has to identify, know a little bit about middle meningeal artery. So you can see the foramen spinosum, the bend by which you identify the middle meningeal artery. Then there is an anterior division and a posterior division. But one has to be very wary of the branch to the ophthalmic, collaterals to the ophthalmic or anastomosis to the ophthalmic artery, as well as the petrous branch which supplies the facial nerve. So the embolization or occlusion has to be always distal to that, and always see whether there is any anastomosis to the ophthalmic artery. If they are always do it distal to the anastomosis, and see go preferentially into the anterior and posterior division as distally as possible, so there is no chance of a facial nerve injury or an loss of vision after this procedure. So this is an angiogram, LFTCA shoot showing the anastomotic connections, showing the choroidal blush after a middle meningeal artery injection. And in the internal carotid artery, you don't see the ophthalmic artery, suggesting that the ophthalmic artery main supply or contribution is from the middle meningeal artery. So this is how the procedure done. This is under fluoroscopy, and the PVA particles are mixed. Let's see some cases. 53-year-old male, history of road traffic accident. Patient is on dual antiplatelet medication, admitted with headache. CT brain shows a bilateral subdural hematoma with, so a patient underwent a borehole evacuation. Sometimes after borehole, you see that there is layer inside, but usually that gets absorbed. But there is some residual bilateral collection. So the patient was asymptomatic, so the patient was discharged. But 1 month later, came with recurrence of headache, and there is a recollection in mainly on one side, minimal collection on the opposite side also. So this is the problem when the patient is on antiplatelet medication. There is a recurrence. The patient underwent selective angiogram of the middle meningeal artery, anterior and posterior division. The branches were occluded, embolized the anterior division, and the anterior division was selectively cannulated, and both anterior and division. So you can see the both the divisions, the anterior division and the posterior division, and it is done beyond the bifurcation, so that any chance of reflux into the ophthalmic artery is prevented. Because the patient had initially had the bilateral middle subdural hematoma, embolization on the opposite side also was done, the anterior division, the posterior division, and this is the angiogram after the embolization. So 2 months later, the patient was they came back without any new symptoms, and the repeat CT shows that there is almost 99% absorption, reabsorption of the fluid which was collected in the subdural space. So this we can achieve only if you plug the leak. When the leak continues, whenever you aspirate or remove the fluid, it will collect again. Case number 2. 86-year-old male, diabetic hypertensive, coronary artery disease with atrial fibrillation on anticoagulation. So surgically, he was a high-risk candidate, and they also did not want to undergo surgery. So this was middle meningeal artery embolization was done as a standalone procedure. That means there was no evacuation done. This is in these patients, and there is significant cortical atrophy, and even when there is a significant collection, and the midline shift doesn't happen, and the patient usually doesn't have gross neurological deficits, even when there is a big subdural collection. So this is the classical angiogram of a patient with subdural hematoma, where you can see a significant midline shift and the appearance suggestive of a subdural collection. This was previously used when CT scan was not available to diagnose subdural hematomas. So this is the selective angiogram. You can see the foramen spinosum here. This is the anterior division, the posterior division. This is the anterior division. And here you can see the typical cotton wool appearance. When you do selective angiograms, you can see the cotton wool appearance suggesting that there is an inflammatory response, neoangiogenesis, and leak along the dura into the subdural space. Selective cannulation of the posterior branch done after embolizing the anterior division embolized, and after 2 months, so the subdural hematoma has significantly come down. Let's see a few more images now. Another patient with subdural hematoma after embolization 2 months later. Another subdural hematoma, a large one, septate one. You have two septate, two membranes, So after embolization, another one with, you can see the septa in between, this membrane in between makes it difficult. So for example, if you just put a burr hole here, this portion will not come out. So this becomes the aspiration or removal through a burr hole will not be effective in these patients, and there is a complete resolution. In our experience till date, we have done 20 cases. All patients had excellent results. 15 cases were combined approach, whether middle meningeal artery embolization was done along with burr hole evacuation, and 5 cases were upfront MMA embolization. That means it was done as a single standalone procedure. None of the patients had recurrence on 2 months follow-up, and none required re-embolization or resurgery. Now, what are the take-home points for neurologists, practicing neurologists? Number one, chronic subdural hematoma is not a simple disease. It's a complex vascular disease of the brain. There is a leak and there is a collection of fluid. It is not just a bleed, but a response to the bleed, which involves quite a lot of inflammatory and neovascularization process, which leads to collection in extensively in the subdural space, not as a single cavity, but as multiple cavities. The inflammatory response and neovascularization plays an important role, and this has to be addressed. Recurrence of surgery is up to the tune of 30%, and in this subset of patients who recur after surgery, at least 50% of them recur again. So it's going to be an ongoing process once they start recurring, especially in patients who are on antiplatelet medication. Sealing the leak, addressing that inflammatory response and neovascularization by MMA embolization is an integral part of treatment. It's a minimally invasive procedure. It can be done under local anesthesia with very minimal risk. And it's very cost effective also. It's not a very expensive procedure. Now, what are the situations where this can be considered as a standalone treatment? That means the solo procedure. When the patient has minimal symptoms, mild cognitive abnormality, mild gait disturbance, has only urinary symptoms, mild leg weakness, only headache, only seizure, cognitive changes alone, minimal mass effect in an elderly, or even with significant mass effect, but there is significant cortical atrophy, minor minimal motor deficits, multiple comorbidities, like the patient has got renal failure, the patient has got liver failure. These are patients, patients with cirrhosis, with hepatic encephalopathy. These are patients who will likely to have recurrence of bleed on antiplatelet and anticoagulation, which cannot be stopped when there's a stent inside or there's a definite indication for anticoagulation, old age, and a patient preference for a minimally invasive procedure. So these are probably the indications where, because what I'm trying to tell you is, a vast majority of chronic subdural hematomas can be treated as a standalone treatment using middle meningeal artery embolization. Now, as an adjunctive to surgery, as a pre-surgical option, when the patient is on antiplatelet medication or anticoagulation, the patient is admitted with subdural hematoma, the patient is on anticoagulation or antiplatelet medication, it takes at least 3 or 4 days for the effect to wane off, and so that the surgery can be done. Immediately, one cannot operate on these patients. So in such patients, immediately, the middle meningeal artery can be embolized, devascularized, so that further leak doesn't occur. So, and the patient can be observed, and if there is any deterioration, then the patient can undergo a burr hole evacuation, maybe 3 days later or 4 days later once the effect is gone. And if the patient is not deteriorating and improving, maybe we can leave it like that. When there is a layered septate chronic subdural hematoma with multiple cavities, definitely burr hole evacuation alone doesn't solve the problem. Significant headache alone. I've shown you the image where there is a significant inflammatory response of the underlying parenchyma. These are patients who present with recurrent seizures, encephalopathy, and significant headache. In our experience, we had at least 3 patients who had complete subsidence of at least a dramatic subsidence of headache after embolization. There was a patient who had continued to have recurrent focal motor seizures, which was not getting controlled with 4 anti-epileptic medications. The seizures completely subsided after middle-meningeal embolization. Encephalopathy patients. And it has been postulated, or there are so many studies going on regarding the role of middle meningeal artery or the dura in migraine. So whether middle meningeal artery embolization helps in patients who are chronic migraineurs, this is a topic which is under investigation and evaluation. Now, adjunctive to surgery as post-surgical, recurrence after burr hole evacuation. When the patient has got, you have a burr hole, the patient which is incompletely evacuated or recurring after burr hole evacuation, the patient needs a craniotomy and removal of the membrane, which can be avoided. Layered subdural hematoma, you have, after burr hole, can do a post-surgical embolization, and when there's an incomplete evacuation after surgery. Now, the last point is when to avoid, or when should not be considered as a standalone treatment. When there's a significant mass effect, the patient is comatose, it's coning, the patient has got a very huge subdural hematoma with significant mass effect, then definitely the patient needs a surgical evacuation. And after that, the one can consider middle meningeal artery embolization. There is quite a lot of literature available on this. Because of the lack of time, I'm not going into that. People who are interested can go through all these literatures which are available on internet. So many studies have gone, and this is come up in a big way. There are a case series of more than 200 cases from different centers, which have shown that this is a very, very useful, viable procedure. So I'll stop here because of lack of time. Thank you for your patient listening. I'll be very happy to answer if you have any questions or doubts, or you want to make any comments or your opinions on thoughts of this. Thank you.